Oh, hey, now, there we go. So as many of you are familiar, we have our rotating topics for our morning echo. So this is the diversion of buprenorphine. Our global objectives, session-specific ones, we're going to look at the prevalence of diversion in patients who are using medications for opioid use disorder, look at some of the risks associated with it, as well as the rationale. So what's driving some of those behaviors, and then identify some strategies that are recommended to reduce the risk of diversion. Special thank you to Russell Spieth. So this is modifying his original slide deck on this topic. So looking at diversion, I wanted to start with the definition. The top definition comes from dictionary.com. So diversion being the act of diverting or turning aside as from a course or purpose. Really thinking about the diversion, turning aside, the movement of medications from the individual that those medications were specifically intended for. The bottom definition came from an article that had one of the better concise definitions of diversion, and it called it voluntary or involuntary unauthorized rerouting or appropriation of a substance. So essentially that the substance is not going directly to the person that it was prescribed for, but may end up in a different, being used by a different individual, and again, being either voluntary or involuntary. So I think that provided a little bit of a broader perspective. The other piece that I think is important to consider as we look at this topic is the definition of misuse. So misuse being any use of a prescription drug that varies from accepted medical practice. This could be changing doses, it could be changing frequency, it could be changing route of administration. But just because that is changed does not necessarily mean that misuse is always abuse. In some instances, misuse could be that a patient decides that they're going to self-taper. So they're starting to wean themselves down, and that isn't the recommendation that had been provided by their medical provider. Or they're having issues with something, so they're trying to change when they're taking their medication, they increase the frequency because they're having side effects. So I think oftentimes these get used together, but there is a distinction between them. Misuse does tend to be related to diversion. Abuse can also be related to diversion, but diversion may also be part of the misuse. It's not always that an individual is going to be abusing medications like the buprenorphine. They may be used for other purposes, and we'll take a look at that in just a couple minutes. In addition to laying the framework for definitions, I also wanted us to take a step back. So this is information from the United States National Household Survey on Drug Use and Health. And they found that the use of a prescription drug that was not prescribed for an individual was occurring in about 17 million people. 27% of them said that they borrowed a prescription, and 23% said that they had shared a prescription with others. So this isn't something that's unique. It's not something that happens rarely, and it's not only for opioids. So the most commonly shared medications were allergy medications. I spent most of this week up in upstate New York at my parents' house, and I will tell you, coming from Ohio to New York, there was definitely a difference in what was growing and what was in the air. Both of my kids were struggling with their allergies while we were up there. So probably not a surprise that some of those medications are being shared, just in an effort to try to make people more comfortable. And I think that's something that we want to keep in mind. Also, antibiotics show up on this list. Some of you may be cringing by seeing that, but if individuals are having antibiotics, keeping some and maybe not finishing their course, they may also be sharing those. So this isn't something that's only specific and unique to pain medication and opioids, even though that's going to be the focus of the rest of our topic today. So pivoting to the focus on diversion for things like buprenorphine, why might this be happening? There's a whole bunch of reasons. In some cases, it may be individuals who are trying to supplement their finances. They're looking for an additional revenue, maybe because they have an unexpected expense that's there. It could be that they're trying to assist a friend. So maybe they see someone who's having difficulty accessing treatment or who is really struggling, and it's done similar to the allergy medication or the antibiotic sharing in an effort to make that individual more comfortable. In other cases, it has been swapped out for a drug of choice. So potentially being able to borrow or barter to go from buprenorphine to a different medication if the individual is craving that and is trying to pursue that. So there may be a whole bunch of different reasons, not all of them specifically down the misuse abuse pathway. So with that in mind, we're going to look at a number of different articles and reports that try to dig down a little bit deeper into diversion of buprenorphine. This one in particular was a survey that was done in over 10,000 patients. They were looking at patients that were in opioid use disorder and trying to identify if they're using diverted medications, if they're supplying diverted medications, and the rationale behind that. When they compiled all of the survey data, they did find that buprenorphine was the fourth most commonly diverted medication. Oxycodone and hydrocodone were by far the most common. After that, alprazolam, buprenorphine, and then methadone was the fifth. Rounding out the top five, that was about 30% reported using or having access to diverted methadone. Interestingly, about 50% that were of patients that reported using diverted medication were using it and had comorbid pain. So they were looking for a treatment to assist with some of the untreated pain that they were having. So interesting, not incredibly clear if all of them were in treatment for medication for opioid use disorder. So were they already on a treatment? Maybe they were on naltrexone or something else and were looking for treatment of pain, but about 50% were trying to pursue diverted medications, did have that. So that may be one of the drivers that we see. For those that are using diverted buprenorphine, there were a whole list of reasons for why individuals were using that. To maintain abstinence. So in some cases, they did not have anything in place. Maybe they weren't actively engaged in a treatment program. So in a way to avoid using other medications, they were using diverted buprenorphine. Maybe their drug of choice wasn't available. What they were hoping to get, they reverted to buprenorphine instead. If they knew they weren't going to have access to other medications or were starting to have some withdrawal symptoms, those were also drivers. In some cases, they were trying to wean themselves off of medication. So moving to buprenorphine and being able to wean themselves off that way. In other cases, less commonly, it was the only drug that was available. It was something that could hold them over, again, just trying to stave off some of those withdrawal symptoms, and the treatment of pain. Buprenorphine can be used for pain treatment. It's not the only one, as we can see for the other diverted medications, but again, that does show up as a potential driver for the use of buprenorphine, diverted buprenorphine. So seeing that there might be a whole host of reasons why somebody might be doing this, is there a target population? Is there patients that we could identify or potentially flag that are more likely to be diverting medications? So this was a survey that was done in methadone patients, so over 300 methadone patients. They had been in methadone maintenance treatment for an average duration of 154 weeks. So these were not new to treatment patients. They had been in treatment for an extended period of time. About half of them were male, the average age was 40, and 20% did admit to sharing medications. When they looked at some of the other factors to try to see if they could predict diversion, both sharing and accessing medication, they found that patients that were of a younger age, so in their 20s to early 30s, were less likely to be sharing medication and less likely to be receiving medication. When they looked at all of the factors, they found that patients that were experiencing financial hardship were more likely. So their odds ratio was 2. So they were twice as likely to be sharing or receiving diverted medications. And some of the other drivers were recent use. So recent use of other substances, including heroin or cocaine, with heroin being a bigger driver than cocaine was. And there were a couple, why are we not progressing here? And when they looked specifically at which medication, so this was just, are you sharing or receiving any medications? When they looked at the specific classes, they did find that there was an increased use, sharing of medications that were likely to be abused. So I guess not a huge surprise, ADHD medications, so the stimulants, the sedatives, pain medications, as well as sleeping medications. The blue bars are the percent of patients in that survey that were prescribed these classes of medication, and the red bars are the percent of patients that were sharing these medications with others. So again, we see quite a bit with some of those medication classes that may be highly sought after, but they're not the only ones. So again, antibiotics did show up, mood medication. So these were antidepressants, as well as bipolar disorder medication and mood stabilizers, blood pressure medications, and again, those pesky allergy medications, about the same percentage of patients that were being prescribed, and 11% of those that were prescribed were sharing those medications. So we do see some predictors for who may be seeking out the medications, who may be providing those medications, and the type of classes that might be involved in diversion. So can we look at maybe where this might be coming from in terms of sources? This was a study that looked at adults that did have recent substance use. So within the last 30 to 60 days, there had been substance use. The substances that were listed, so any opioids, heroin, cocaine, or potentially methamphetamine. They did a prospective evaluation, and then they followed up with the patients 6 months later. What they found was that use of buprenorphine, diverted buprenorphine, over the course of the lifetime. So any of the patients that were surveyed, about 70% of them had used diverted buprenorphine at some point. About half of them were using it sporadically, but almost 10% of them were using it on a daily basis. Those patients tended to be ones that did have issues with access to treatment. When they looked at sources, where were these coming from? They were much more likely to be coming from a dealer, and then friends. About a third of them were getting them from friends, about 7% from family, and about 1% from a spouse or a partner. So not necessarily just from individuals they had close access to, so friends or family members. There are other reports where those numbers are flip-flopped, where access comes a little bit more from friends and family. So it may really depend on the location that you're in and the patient population that you're working with. When they looked at predictors, so was there a way to predict who was going to be accessing diverted medication? They found a number of factors. The past month use of a benzodiazepine actually was a predictive factor. So they were less likely to be using diverted buprenorphine. They may have been more likely to be accessing additional services, including mental health services. But the drivers for this population were inability to access buprenorphine. So their odds ratio was 7. So that significantly increased their risk of accessing and seeking out diverted medication. And then past use of OxyContin, of methamphetamine, and of alcohol increased the risk. So individuals that are using other substances do seem to be a population that is actively seeking out and using diverted medications. And then mental health conditions. This pops up a couple times, but in this particular study, they looked specifically at the diagnosis of generalized anxiety disorder, and that seemed to be a driver for seeking out diverted medication, specifically buprenorphine. So let's zoom in a little bit on Ohio in particular. I did update this from last time. So this is the osamagram with data from June of 2020. The list has gotten quite a bit smaller. So looking specifically at the availability of buprenorphine in the different regions across the state where they're tracking this, they have seen an increase in availability. It continues to be widely available in Columbus. That's unchanged from January. Akron-Canton actually has moved from decreased availability of buprenorphine to the increased availability of buprenorphine. So that being a little bit more common. And then Toledo did the flip-flop. So it had increased availability of buprenorphine and now is reporting decreased availability. Across the state, use of stimulant medication, so cocaine and methamphetamine does tend to be up or holding stable across the board. So that seems to be a lot more in flux than some of the other opioids. And there's a little bit of variability with the illicit use of gabapentin as well. There are some regions that have increased availability of that. However, the diversion of buprenorphine doesn't appear to be one of the highest trending medications, at least for that June 2020 data. So recognizing that it is happening, there are still some pockets where it may be of a concern. What can we do about that? This was a survey done of prescribers who did have their X waiver and were prescribing buprenorphine to at least one patient. They collected data from 2014 to 2017. There was over 1,000 patients. And what they found was about 80% of prescribers were assessing all patients for diversion. So about 20% were not systematically, routinely assessing all patients. About half of them did believe that diversion was a moderate problem, and just under a quarter of them believed that it was a significant problem. For those patients that had responded, we did see quite a bit of variability. Most of them were seeing patients on a relatively regular basis, especially during the first couple months of treatment. So when they had patients who were early in treatment, they were seeing them more frequently. And we did see concern rates. So as they were looking at their concern related to diversion, there were a number of different steps that they took. So about a third of them did use twice monthly appointments. A little over a quarter were increasing it to weekly appointments. A third of them didn't report doing any medication counts at all. But about half of the respondents had terminated a patient due to diversion. So we saw quite a bit of variability in the approaches to this, despite the fact that quite a few of the respondents did feel that this was a moderate or significant problem. So what are strategies that are encouraged by some of the prescribers, reported by some of the prescribers, as well as identified in some of the ASAM recommendations? The frequency of office visits, so increasing some of those touches, potentially in patients who have other comorbid conditions, mental health conditions, as well maybe as those with comorbid pain. Encouraging urine drug testing on a regular basis, having pill or film counts or observed dosing, and that could be intermittently, not necessarily something on a scheduled basis, especially early in treatment. They encourage the use of the lowest effective dose. So if a patient has been stable at a particular dose, is that the dose that they still need, or is there an ability to drop the dose down a little bit? If the patient doesn't really need all of that to continue to be comfortable, then that could potentially reduce the amount of supply that's available. And then education for the treatment teams to be watching for some of these risk factors, education for the patients, as well as their family members and caregivers that may potentially be around. Because as you could see, in some cases, it may have been that they accessed it from a family or friend, a family member or friend, but it may not necessarily have been something that was supplied to them by that person. It was just that they used their supply to get access. So to wrap up, diversion for patients with opioid use disorder is definitely a consideration. Something that's a little unique for buprenorphine because they are able to have an at-home supply. in looking at risk factors, there isn't one thing that's going to say this is the complete high risk group. Younger patients may be at a slightly lower risk. If they do have comorbidities, mental health diagnoses, or pain, that may be a driver to increase their risk. If they're actively using other substances, that might be an increased risk. And if they have limited access to care for a number of different reasons, that also may increase the risk of them attempting to pursue diverted medications. But there are steps that can be taken, and as many that can be incorporated into practice can help. Probably not going to shut it down to zero, but may help minimize that as much as possible. With that, I'm going to stop my share and I will turn it back over.
All right, Dr. Dugan.